I am so excited today to be interviewing literally the most famous guy on Dental Town. I mean, seriously, John, you've been on Dental Town. You got what, 7,000 posts. Your cosmetic work is just unbelievable. I shouldn't even be doing this on video because you're the whole deal. You're the cosmetic dentist. You're beautiful. I've never felt so bald in my life as looking at your hair. You got enough hair for three Justin Biebers and a smile to match. I just want to tell you, first of all, dude, just congratulations to all your success. I mean, unbelievable. And I want to say that a few of us townies like Howard Goldstein and me and Pete Janicki, who's a great friend of both of ours, we saw. How many years ago did you join Dental Town? What year did you join?
God, I think it's been like 4 or 5 years now.
Yeah, which
I
sounds like
mean,
a long time to you, but I got on that thing in 1998. And so you got on in what, 2010?
well, you know what? I actually got on in 2002, but I lurked forever. And I think it was probably about like 2009, 2010 that I started actually posting.
Man, and right when you started posting, everybody's like, dude, this guy is gonna skyrocket all the way to the top. And you are at the top. You are at the very top of the game in the richest, biggest country in the world, the United States of America. And I mean, your work, I mean, really, you're like Picasso in dentistry. You're just amazing. So I want to start, I want to back up. So what year did you graduate?
I graduated dental school in 1998.
Okay, 1998. That's when we started Dental Town. So my first question to you, John, is a lot of dentists, I'm talking about the dentists who just graduated. Let's talk to these people, these 5,000 kids who just walked out of school last May, and another 5,000 are walking out last May. And a lot of times kids start whining about, there's corporate dentistry. When I got out of school, it was managed care and HMOs and it's always something. But I look at the whole country. I mean, God, in 1862, America lost 800,000 people in the Civil War. Then they went into World War I, which was the same time as the Spanish influenza, which when 5% of the planet died of the flu during World War I. Then we go into the Great Depression. Then we go into World War II. And what are you whining about? Corporate dentistry? I mean, give me a break. Then I see guys like you who just made their own luck and just is crushing it on so many levels. So what I want you to my first question to you, John, what do you say to the 5,000 kids who walk out of school and go, but John, I have student loans and there's corporate dentistry and Obamacare is coming. How do guys like you just like whatever and just rise to the top? What was your secret to your sauce that accounts for how you made it? Was it just pure attitude? Was there something you were doing that you saw some of your classmates not working on enough?
Yeah, I mean, first I want to thank you for everything you've done for me. That great introduction. I mean, I'm totally humbled sitting here in front of you, on here, and I'm really honored to be here. So I thank you again for having me. But going into what I felt was a big part of my success is, I was like everyone else out there. I graduated, I did a residency, I finished up at Lehigh Valley Hospital in Allentown, Pennsylvania in 1999. And, right out of my residency, two of my best friends from dental school, this guys Scott and Shallon, we decided to open up a practice from scratch. We had no money, kind of had no jobs, and we had no patients. So we've opened up a practice, opened the doors, and the three of us got together and said, you know what, we want to have our own practice. And in order to do this, we're each going to get jobs in other offices. So at the time, who was hiring? I mean, I went out and I worked into a corporate office for a couple months, and I quickly realized that, what, this isn't for me. They want you to see more and more and more in such a short amount of time. And it really wasn't quality type dentistry. So, thank God I got a phone call from, my now partners in South Jersey where I'm at. And they said, hey, we're looking for a guy to come on as an associate who wants them to become a partner. And so for 3 days a week, I worked in my current practice, and 2 days a week, I worked with my best friends out of school. And, I sat there, waited for the phone to ring. We had no patients, we had no staff. And what was I going to do in the meantime? I mean, I read. I mean, I subscribed to AGD, to JADA, to all these companies, and you know, I read as many journals and even went back and looked into the textbooks that I didn't bother to read when I was in dental school. And one of the things that really stood out to me when my residency was continuing education. I mean, I didn't know anything about continuing education, you know, when I was in dental school. And, you know, even though we saw some of the things, you know, when we get out of school, what continuing education is really thrown at us? Well, it's thrown at us by Delta Dental, and it's thrown out of us by our local reps, and come an hour and hear about this, have a lunch and learn and hear about that. Well, I was in my residency. I mean, in a year, I saw guys like Dennis Tarnow, Gordon Christensen, John Kanka, you know, all of these guys that in 1999, they were it. And, you know, they came to our continuing education group in Lehigh Valley. And I mean, this really blew me away. And I really said to myself, you know what, it's time to set the standards higher. And, you know, I saw examples of what these guys were doing. And I said to myself, this is what I want to do. And, you know, I just became a CE junkie. And literally, I mean, again, I came out of school. I wasn't making a lot of money. I borrowed my way through dental school above and beyond. So I graduated in a huge amount of debt. I mean, I understand now guys comparingly and girls have more debt than I had, but I was over $150,000 in debt. I wasn't making a whole lot of money because 2 days a week, I wasn't earning any income. And so you could figure how much money could I make as an associate working 3 days a week? And I still took, you know, a seminar in a weekend that cost $2,000 or $3,000 from some great guys. And you know what? I just made a commitment to myself saying, if I'm going to invest in this weekend-long seminar, I'm going to get something out of it. I'm going to learn. I'm going to dedicate myself, and I'm going to come back a better dentist. And I will say that, you know, you ask my partners month after month after month, I would take a new course. I would come back. I would build on it. I wasn't, you know, I wasn't a Yahoo that I'd come back and do like, you know, I wouldn't go and do an endo course and come back and start placing implants. I mean, it wasn't like that, you know, but I would come back and I would just be realistic. I would start introducing new procedures. I would start doing better in the procedures that I was already doing. And that steadily started to steamroll.
Let's go back to those 5,000 dental students and let's address the two most common questions that dental students ask on Dental Town and when I go and lecture in dental schools. Number one, should I do a residency? I want you to talk about that's a big decision. Let's talk about that. And then the second one I'm going to follow up with that is a lot of them see 9 specialties and say, should I specialize? Address those two questions for the 5,000 kids that are a senior in dental school wondering if they should do a residency or specialize.
You know what? I thought to myself that there was a point, believe it or not, that I had the idea of becoming a pediatric dentist. And luckily, I was fortunate enough to run into a dentist and really talk to him about what I was thinking. And, you know, he kind of turned me around. He said, "Are you crazy?" He was like, "Why would you want to become a pediatric dentist? You're going to get everybody else's headaches. And, you know, you could open up, become a family practice and see all the children that you want." And you know what? That really kind of hit home to me because, you know what, maybe I was a little naive, but I didn't realize once you specialize, that's all you do is specialize. So to those people contemplating being in a specialty, you know what, pediatric dentistry could be great. You kind of have like geographic success in that teeth are going to fall out after a period of time and you don't have to worry about long term. But then you also do see kids go off and leave your practice. So there is somewhat a constant changeover. If that's interesting to you, then I would say go at it. You know, as far as being a periodontist, if that's something that interests you, placing implants and doing perioplastic surgery, have at it. That's fantastic. But I would look at it like you need to have a great personality. You have to go out on top of having great skills. And you really have to be able to, you know, wine, dine, and make friends with a lot of area general dentists in order to rely on the referrals. Now, even when your dentistry speaks for yourself, if your personality doesn't match and you don't have great chairside skills, no one's going to refer to you. So you kind of have to have both of those sides. Now, going into the residency aspect of it, you know, to me, I think I know a couple people who were gung ho to leave dental school, go out and start making money. And I would say I think that that's a bad thing to do. And here's why. When you come out of dental school, I mean, a lot of dental schools, they try to really beat you up. I mean, it's all about learning how to be, the big boy network, and it's this and it's that. And unfortunately, a lot of professors, maybe they shouldn't be teaching. And they kind of beat you up when you're in school, and you get out and you kind of have this bad taste in your mouth regarding being a consummate student for the rest of your life. And the last thing you want to do is continue to be a student. You want to go out and you just want to practice, and you want to show what you can do. Residencies, as I've seen it, they're a little bit different. You're dealing with a lot of people who are involved in residencies like myself who want to teach 1 or 2 days a week. They don't make a living doing it. They do it because they love to teach. And you get out, you get involved into a different aspect of dentistry. You learn really how to practice dentistry. You learn how to and really become a better student over a long period of time. So I would say from my experience, I would highly recommend looking at a good residency and getting involved, because it really could change your whole scope of dentistry.
Yeah, one of my best friends, Dr. Tim Taylor in Chandler, who practices in Maricopa, he just goes in Friday. He does his 410s Monday through Thursday, and he literally goes into dental school all day Friday, and he'd probably pay them to do it. I mean, he gets this little amount of money that he could go into his own office and do one filling and make more. And he goes in and spends the whole day just because he's passionate about the students and giving back and all that kind of stuff. I want to ask some. Now I want to go back and talk to these dental students that are about 5 years out of school. This is what I'm hearing their questions loud and clear. They say, Dr. Nosti, I graduated with $300,000 student loans, blah blah. If I want to be a good dentist like you, do I need to pay 6 figures for a CBCT? Do I need to pay 6 figures for a CAD cam? Do I need to buy a $50,000 laser? Can you address those 3 big things that could be as expensive as your student loans? In fact, if you had a CBCT, CAD cam, and laser, that could be your student loan indebtedness. So should they double down on all those 3 things? And so go through CBCT, CAD cam, laser, any order you want, because those are big, high dollar ticket items.
And this might be the shock to a lot of people, but I don't have a CBT in my office, a CBCT, and I don't have CAD cam in my office.
Are you serious?
Could you imagine? So
is that because you do a lot of anterior work and you don't want a monolithic block, and you'd rather have feldspathic stacked porcelain from a rockin' hot lab? Like, I know you're a big fan of the lab right here in my backyard.
Absolutely.
Gold Dust.
Yes.
And that does phenomenal work. Gold Dust Dental Lab. What's their www? Is it Gold Dust Dental Laboratory?
GoldDustDental.com.
GoldDustDental.com?
Yeah, GoldDustDentalLab.com is their website.
Now this will be in the notes, so make sure if you follow up on the email, because for my listeners, they might be in an hour commute home from work and some interstate. So my viewers don't have to write anything down. We always offer a transcript with the link. So you make sure that link is in there. So but is that why, John? Because you want handcrafted aesthetic feldspathic porcelain, or why did you not buy a CAD cam?
I think there's a couple things. I mean, first of all, it's not only just because I do a lot of anterior aesthetics, because I think in order to be successful, you have to be able to do a lot of still single tooth dentistry. So I still do a lot of bread and butter inlays, onlays, and posterior crowns. And just looking at it, the numbers weren't right for my practice. I mean, if you have multiple doctors in your office, and each doctor likes to do a certain thing, and you can hire, in our opinion, an assistant or a restorative hygienist who can then work the system and be the stain and glaze and do everything else, then I think it works well. I've talked to a couple of great people on Dental Town who are trying to push me into the CAD cam realm. And, just right now, the numbers don't make sense. And I think you have to look at it. How much are you paying from your lab? How much are you still paying with blocks and burrs? And how much time then is it going to take for you in order to get the ceramic that you want coming out of the machine in order for that to be worthwhile for your practice. And just looking at it, it hasn't been something that we've really entertained in my office yet.
Now, have you entertained optical scanning of teeth for impressions as opposed to an impression material? Have you thought, what has your amazing mind thought of that technology?
So we have looked at that, and we've looked at a couple different companies and a couple different scans, and I've had some in my office to try out. And we've had issue with uploading some of the scans. We've had issues how some people, they sell you a scanner, but then you have to pay a usage fee per scan. That's as much money as the impression material. So that doesn't kind of really make sense, unless you're trying to just get rid of impression material in your office. And like someone like myself, I still do a lot of splints, and I still do a lot of like study model analysis. And
splints for implant guided surgery or for TMD?
Everything. Implant guided surgery, TMD.
Are you placing implants?
I do not place implants.
Okay. But do you have a CBCT?
We do not have a CBCT, and mainly because we don't place implants in my office. We have a new associate, and he's interested in it. And one of the things that we haven't even gone that realm of allowing him to place a lot of implants is because my partner and I, we do refer to specialists who do use CBCT.
And okay, and what about laser? The last one.
I actually have several lasers in my office. So
in the price range of what?
In the price range of the cheapest one would be AMD's Picasso, and
by
the most
infamous great Alan Miller.
Absolutely.
God, I love that guy.
It's a fantastic laser. I love it. That's probably my cheapest laser and my go-to diode. And the most expensive laser I have, it's still running, so I knock on wood, is a VersaWave by the defunct Hoyo Cambayo.
And was that a diode or was that a carbon dioxide?
It's an erbium.
An erbium laser.
It's hard and soft tissue. I'd be lost without it. But right now it's still running strong. So do I think people need to have a laser in their practice? I think you need to have a way to change soft tissue. I wouldn't use a electrosurge, and with such great lasers like an AMD Picasso Light that's so inexpensive, I do think that's a technology worthwhile investing in.
So who's more fun and handsome to go to dinner with, you or Alan Miller?
Oh, I got to give it to Alan.
You got to give it to Alan. He is so fun to go to dinner with. So John, I want to ask you a personal question. Why do guys like you like to share so much on Dental Town? I mean, you've spent a gazillion hours sharing case on Dental Town. Why do you like to leave a very busy, successful cosmetic and practice? I know you're touring the country with some great people. Leanne Brady, who's in my backyard here in Phoenix, is an amazing clinician. Jason, who's probably the top photograph guy, wouldn't you say, in dentistry? I mean,
I would say Jason's on a whole nother level.
Yeah,
Jason,
I mean, I don't
down in Ponte Verde, Florida. He's phenomenal.
Yeah, his photos are almost as good looking as his wife.
Yeah,
and Mike Smith, who's also in the backyard. So I want to ask that question. Why did you? I mean, for 7,000 posts, I mean, you literally put a gazillion hours on downtown, and you leave a very successful practice. And I look at you guys out there, and I know you can't be making what you would make if you were just doing an anterior veneer case in your office. What makes you do that? What drives you to do that? And talk about your clinical mastery. How did you hook up with Leanne Brady and Mike and Jason? And how did the four of you, I mean, is that like the Three Musketeers, or how did this even happen? Will you go into the birth of that?
Absolutely. So
were you all four serving at the Betty Ford Center at the same time, and you figured this out in rehab? I mean, how did this all come about?
So, I looked at it where, first going back to Dental Town, I mean, why do I do that? I really looked at it where a lot of great people have shared time with me and shared their procedures and how they got to where they got to, and are able to be successful in doing that. And why do I go on Dental Town? Why do I post? And you're right, we don't make any money. I surely can make more money being in my practice and doing it. But one of the greatest things about Dental Town and being able to share the information is, getting an email once in a while and having people tell me, hey, you know what? I did what you told me to do and it made the procedure unbelievable, or thank you so much for sharing. It's about the camaraderie. We're here in the whole dental world together. And, it's not about competition. It's about how we can make each other better dentists and how in return we can make our patients' lives a whole lot better. And, that's why really I love teaching and I love the avenue of Dental Town. I mean, just to go out there and post and hit so many people. And we thank you for starting that. It's a fantastic forum.
Well, you got to thank Al Gore. He invented the internet. I just went for the
yeah, that's true. I forgot. Of course, don't forget Al Gore. So how did the Four Musketeers get together? So Jason, Mike, and I we met teaching with the Hornbrook Group.
Oh, really? That's your roots. Okay, in Chicago or in Illinois, or was it?
Yeah, well, we were all over, but we were based out of Chicago for a number of years. And when the Hornbrook Group ceased to exist, we all formed, including David. We formed the Clinical Mastery series.
Oh, David Hornbrook's in the Clinical Mastery.
He was originally.
He was the founder.
He was part of the founding members, like me, Mike, and Jason, and but unfortunately, with David's schedule and what he was doing, he no longer became part of the group after a couple of years.
You can feel free to say that when he lost his thumb, you fired him. You can. He had a disability, and you just fired him with a disability. You mean, rude guy, you.
Absolutely. But following that, Mike and Jason and I were doing it together for a couple of years, and Lee a couple of years ago decided that she no longer wanted to be part of Spear Education as much. She doesn't burn any bridges. Everybody knows she was a clinical education director for Pankey for a long time, and then from Pankey she went to the Spear Education, and when she felt like she had done everything that she could do with Spear Education, she kind of went her own way and was doing her own thing for a year or so, and she came upon Clinical Mastery, and the opportunity came for her to join the group, and we're very, very, very happy to have her. She's unbelievable. I mean, such a great individual, and kind of shares the same things that Mike, Jason, and I share, and that's just the love of teaching and trying to again make dentistry just a better place for everyone. So,
and what I love most
about
about
women too,
and what I love most about you four teachers is in dental school, some people teach you and they make you feel bad or feel dumb. And then other people are like you and Leanne, where you can make the most complex so simple, and you make everybody feel better, and they feel motivated to go out and push their limits a little further.
Absolutely, that's what it's all about,
Almost, I mean, it seems like when you had your last course in Phoenix, some of your students were driving to the airport, like Gigi from San Francisco, calling me just saying, "Man, that was the greatest," and they just feel so empowered and motivated, No one leaves your course and feels like I'm dumb and I can never do what you guys do. They leave that place and say, man, I can't wait to get back to my practice and try that too.
That's our goal. Completely. Because, how many times have you taken a continuing education seminar and you felt, you left there feeling like you were dumber than the person who was speaking up on stage. And that's not what we're about. We're here to try to help everyone else elevate their practices.
So I want to say one thing that you kind of lightly said, and maybe you knew you said it powerfully, but when I look at the greats, and I've met them all, I've met really all the greats, and I mean in their office, seen them practice things. I don't care if it's Omar Reed to you. When you walk into an operatory, it's just karma and energy and fun and smiles, and they just want to do it and fix it up. And then when I go into that dental office that's can't get over 300,000 a year or 400,000 a year, and they walk in there and it's just low energy, and they walk in there and they sit down and they point to the x-ray and they start talking about an interproximal cavity on the distal side causing irreversible pulpitis, we're going to need endodontic therapy and a post buildup and a full coverage restoration. John, can you teach charisma? Can you teach a personality? I mean, you have actors and movie stars. I mean, obviously, some of these famous movie stars they cry when someone really didn't die,
Right.
and can you teach that karma and energy?
You know what? I think you can, because, this is kind of going to go back to my high school wrestling days. And, two big sayings stand out to me from high school. And that the first one, which was written on our wall in paint, painted on our wrestling wall, was victory is reserved for those who are willing to pay the price. So that was number one. And the number two was actually was a quote given to me by Jim Jordan, who was like a four-time NCAA wrestling champion, and then has gone on to become he's in something in government. Quote me wrong, he might be a governor, but he plays something in government. But Jim's quote was, "The amount of confidence you have is directly proportional to how hard you have worked." And I kind of look at that and translate it to being, you know what, if you walk into a room and you just look at the patient and you look in their eye and their treatment plan you're going to give them is wholeheartedly the treatment plan for the patient, I think you can be very confident in yourself and look the patient in the eye and tell them what they need. I think we start looking away and we start getting down on ourselves when, we're either questioning what we think needs to be done, or if we're not confident in our skills. So there's two things you really have to look at. Number one, get confident in your skills. Practice. Take a Typodont. Work on that. Do anything you have to do in order to get confident in your skills. And then to get confident in your treatment planning, maybe just, read a little bit more, and believe in whatever you're telling the patient. There might not be a right or a wrong, but sometimes it's a right now. There could be a time. I had a patient just in today as an example, if I can keep going about this. Guy's 80 years old. He's got a cavity on the distal of number 31 that is probably within 1 millimeter to 2 millimeters away from the alveolar crest. So I don't do molar root canals. It's a second molar. I send him to the endodontist, and I tell the guy ahead of time, like, listen, honestly, this tooth is totally borderline. I think you talk to half the doctors out there, they're going to tell you get it out and get an implant. You talk to the other half the doctors, they might say, yeah, you know what, we can save it, but. And then I just talked to the patient. I said, what is it that you want to do? The guy's like, I'm 80 years old. I'm not looking for forever. I'm looking for right now. And I says, okay, you know what? If you want to get out of pain, let's go get the root canal done. Let's at least start excavating the decay, and let's see how far it goes. Then the endodontist calls me, and he's a little bit nervous. He's like, well, John, I don't know. This tooth is borderline. I'm worried about it. I'm this, I'm that. And I said, well, did you talk with the patient? Did you just express your concerns with the patient? And it's talked again with the patient and said, what do you think? Here are your two options. It's either A or it's B. And don't necessarily be so concerned about choosing the right one for the patient. It's A or B. Whatever the patient decides is going to be good for that patient. And I think a lot of times when we get that fear off of ourselves, and just tell the patient wholeheartedly what you would do if it was your tooth, I think that goes a long way. A lot of times, again, be educated, be confident in your skills. And when I sit down with patients, granted, there are times that I'm high energy and people are coming in like, oh, I want to smile. And it's so great to be like, oh, I'm going to give you a great smile. It's going to be wonderful. It's this and it's that. But then there's people who come in who are very logistic thinkers. And, they're analysts. And they want to sit there and they want to fold their hands and they're not going to get very excited about 10 units of the smile design. They want to know that what they're doing is going to be structurally sound. It's going to work well for them. And I'll just sit there and I'll talk to them very calmly and I'll say, you know what, this is the problem that you have when you're in my office. This is what I'm going to recommend that you do in order to correct that. And there are a lot of times that I'll finish off by saying, if you were my brother, if you were my sister, if you were my father, this is wholeheartedly the treatment that I would do on you. And I think, doing things like that and just having the patients understand that you're concerned for them, I think that sells your treatment all day, every day.
I had no idea we had that in common. I was a high school wrestler. I have four boys. I started them all at 5. In my garage, I literally have a professional wrestling mat made in Pennsylvania for 25 years. And my boys and I have spent more time wrestling than probably any other thing we've ever done. It was just a wrestling family. In fact, the only reason I really am a dentist is because my dad was begging me to drop out of high school to go work with him at a Sonic Drive-In restaurant. He thought high school was nuts and dumb and a waste of time. And the only reason I went to high school and made good grades, because if you made a D, you couldn't be on the wrestling team. And I literally only went to high school for the wrestling team. So if it wasn't for wrestling, I would be a Sonic Drive-In manager. I want to ask you I want to ask you some more questions. For a cosmetic legend like you are, if you were doing anterior work, well, I can't say anterior work on me because I have never shown my smile, just to my listeners. I never show my smile in any of my photos. And I went to John, asked him what he would do for me, and he referred me to a vet to be put down. And I thought, wow, that is. I said, "Are you sure, John? There's nothing." He goes, "No, dude, you need put down. You're an old dog. You just need shot like a racehorse." But John, to these young cosmetic dentists, I want you to talk about this and go into everybody I've heard that's seen you live in your clinical mastery deal. Literally, dude, you're like their number one fan. 100% of the people that I've met that went to your course, I'm serious, is a raving fan. I've never heard anyone say, "Oh, it was good." It's not like, "Oh yeah, I learned some pearls," or there's an. It's like, "Oh my God, oh my, you're just that magnetic teacher." In your course, I want you to talk about what is the curriculum of clinical mastery, and then answer the most common question on Dental Town about cosmetic dentistry. If it's an anterior case, corner to mouth, would you be doing Emacs? Would you be doing Bruxer's a new big word, or are you old fashioned and like the feldspathic porcelain? So would you be looking for some of those labs on Dental Town that do a lot of feldspathic porcelain, like the way they did it 25 years ago? Or do you like some of these modern fancy materials from like Ivoclar or Bruxer? And also, being a cosmetic dentistry, do you ever do gold? I have 7 restorations of my mouth, and all 7 are gold. Because I figure if you're short, fat, and bald, it doesn't matter what your teeth look like. I just wanted to go total longevity. Answer all those questions.
You're going for the bling. It's so funny. Just I was on vacation.
I'm going for a grill. That's what you. I'll go to you and you can do a gold grill on me. This says Dental Town.
We talk about bling. You know what? There are times that I talk to patients about doing gold, and I'll be honest with you, there's people still choose to have tooth colored restorations. I find that more patients allow me to do gold if they already have gold. But saying that, I still do think that a lot of the new ceramics out, and you can call Emacs new when it's really been around for 6 or 7, even 8 years now. So it's been around for a long period of time.
Now,
10 years.
Is Emacs just kind of an evolution of Empress back from when I got out of school? Or is that an oversimplification?
I think it's an oversimplification. Empress is lucite reinforced, where Emacs is lithium disilicate. So some people try to say that it's Empress 2 reformulated, and that's still not as correct as it is. It's new material. It started out with a brainchild of Empress 2, but it's totally have evolved into something completely different. So Empress is lucite reinforced, Emacs is lithium disilicate. So if you ask me as far as cosmetics go, if I have someone who comes in and it could be minimal prep, light prep shades, no occlusal breakdown, really occlusion, I don't really have to worry about redesigning anterior guidance, and I'm looking for some gorgeous dentistry, I still have a tendency to lean back towards Empress. Part of that could be the fact that you know what? I started doing it in 2000, and I still love how Empress looks. I think there's part of that, and I still think there's a part of, Emacs. As good as Emacs looks, there are some times where I think in in situations it could look a little bit grayer. Um, Not gray in terms of black and white, but it's a little bit different. Saying that, when I have a patient who comes in who has wear and they have breakdown and they're looking for something that they want longevity in a rehab where even their teeth, have kind of failed them, I'm not even thinking twice. I'm going to Emacs because it still gets me a great look. And the strength of it is absolutely unbelievable. I mean, it's the strongest bondable ceramic out there. Do I go to Bruxer? I don't, because I look at it in the anterior aesthetics portion of it. If they're going to layer Bruxer to make it look good, well, then it's going to be weaker than Emacs, and I can't bond to it. So then why would I choose that? To me, it's going to be a weaker and a less aesthetic restoration. So Emacs has it over Bruxer. When you look in the posterior arch, let's say second molars, will I do a monolithic zirconia on a second molar severe Bruxer? I have done it, but to me, it has to be in a situation where I'm doing a full mouth reconstruction and I'm doing monolithic zirconia over monolithic zirconia. And especially in situations I can't bond. If I can bond, I'm still choosing Emacs over Emacs. Studies have shown it wears very similar to enamel. It's kinder to opposing enamel. So, and I can adjust it and I can polish it back up to its original form coming from a lab. Where, there's still questionable out there whether or not you can achieve that with a monolithic zirconia restoration. When monolithic zirconia came out, let's say 5 years ago, at the time they said, well, the restoration you want to have, it should be polished and then it should be glazed. And, they no longer recommend that. Now they're recommending only a polished restoration because they've shown in about a year's period of time, the glaze wears off. So, what are they going to tell us in another year or two? Are they going to tell us, well, don't do polished, or, after a year or 2 or 3 years, the polish breaks down and now you have a lot of opposing enamel breakdown? So I'm not so hung up on the monolithic zirconia yet. Now, saying that, where does zirconia have its place in our
well, you could cement a monolithic zirconium. You can't just cement an Emacs, correct?
You can cement. No, you can cement Emacs as long as it's over 1.5 millimeters thick. You can cement it. So
as long as it's 1.5 millimeter
thick, and like the occlusal, as long as the
occlusal, as long as the Emacs is 1.5 millimeters.
Yes, yes, okay. Yes. So as long as you have more than 1.5 millimeters of occlusal clearance, you can cement it with anything. It's as strong as if you bonded it. I have a tendency to bond a lot of mine in, but as long as it's that thickness, you're good to go in Fuji-Sem, like a Reliax Unisem, Multi-Link, Speed-Sem. Take any SEM you want and you can put it in pretty much.
Okay. Well, I'm still using Elmer's glue.
There you go. That works well too.
That works because of the horse hooves in there. That's
no,
I'm sold on the horse hooves. Go into clinical mastery. What tell us about your curriculum, because you have 4 different teachers. It's 4 of you. So do you teach 4 different subjects? Is there overlap? Is it a curriculum is clinical mastery like you sign up for this and take session 1, 2, 3, 4, and then you did clinical mastery? Or talk about that. And it's clinicalmastery.com, correct?
It's clinicalmastery.com.
Okay, talk about that. That would be is any of it, is it lecture? Is it over the shoulder? Is it all the above?
It is all the above. I mean, we looked at it where, we have a couple different tracks that you can follow depending on what you're trying to get out of, going through like a continuum. Like Jason teaches photography. So if you sign up for photography, Jason's going to be the guy who's going to lecture to you.
Olitsky?
Jason Olitsky, correct. But if you come and you take any one of our occlusion series, and that's going to be, it's mastering functional dentistry, mastering complex cases, and mastering full mouth reconstruction. You know, through those 3 courses, you're going to get a heavy dose of myself, Mike Smith, and Leanne Brady. So 3 of us are involved in teaching that core group. Now, we also offer a treatment planning seminar. Now, that seminar is, you know, kind of interchangeable anywhere in the group. You can come and take that course after you've been through a couple courses. You can come take that course to start, and that is going to be taught by all 4 of us. It's Jason Olitsky, Leanne Brady, Mike Smith, and myself. And
Now, is treatment planning diagnosing treatment planning, or do you also talk about presenting the case?
All of it.
Explaining to the patient, trying to say the dirty word, sell.
Absolutely.
Well, we have to rate this podcast R since we said sell.
So what we basically do is we start out and we give you like a form and a decision tree to follow, to go back to examine your patient, and then we each present different patients who present to our offices for different things, like extreme cosmetic case, implant cases, broke down wear cases, full mouth reconstructions involving patients with TMD. And each one of us will take you through cases from our practice and present to you, this is what we did in our diagnosis, this is what we did for our case presentation, and this is how we executed the case. So you're basically going to get, you know, 4 different speakers talking about different cases from their practice and giving you different nuances and how we do what we do in our practice. And that, again, that could be a standalone, that could be in the beginning, middle, or at the end of the series.
I want to make one observation I've had, and I want to know if you've seen the same observation. I've lectured 1,500 times in 50 countries, and I've always noted that, you know, the right half of the room is one doctor who brought his wife and 2 assistants and 2 receptionists and hygienists. So it's like the right half of the room is like almost all staff. And the left half of the room, it's all solo dentists. And all the dentists on the right half of the room, they all make twice as much money as the dentist on the left half of the room. And all the left half of the room, it comes by themselves to save money. And I was wondering, do you recommend bringing, I mean, like when I hear the treatment plan deal, I mean, it's almost like I'd send my staff and I wouldn't go.
Yeah.
You know, so do you see that common denominator that the dentists who get their staff fired up and educated in CE just do financially so much better than the ones who come alone?
100%. You know, I'm even going to build on and come back to that question, because we do offer 2 over-the-shoulder courses. One's given by Jason, where you get to go in and you get to see Jason prep and seat an anterior cosmetic case or anterior aesthetic case. And then, so you get to see him prep, diagnose, prep, temporize, and then you also seats a 10-unit case. And then myself, I give the over-the-shoulder full mouth rehab course over 2 weekends. So it's 1 patient. You see me diagnose and prep a full mouth rehab, and then you see me seat the full mouth rehab. Now, I do think there's courses that are advantageous for docs to bring their staff to. The over-the-shoulder course, I think that's imperative. You know, if you're not bringing one of your assistants, you should definitely bring both of them, or just bring the assistant that you work with the most, who's going to at least be able to go back and teach your other assistants. I think that's huge, because to go back and see how my assistant and I work together, you can't communicate that, and you can't give that expectation back to your assistant unless your assistant sees it happen. And it's the same thing I know with Jason's assistant and how they work together. And there's this seamlessly thing that happens where, and I'm sure you know this, you know, we've inserted so many units together, there's so many times that my assistant even can tell when something goes wrong, and then what plan B to start following after that. And then, of course, we talk about it in the course, but when an assistant sees another assistant work at that level, that's going to push her to work at that level for you. And honestly, that can't come from you. It's not, you know, it's not going to come from the dentist. That's one thing. The other thing too is bringing it back to our lecture courses. You know, our Occlusion 1 course, that is an unbelievable course, not only to bring your assistants to, but a lot of times even to bring your hygienist to. Because, you know, you might have told your hygienist 1,001 times about This is attrition. This is abrasion. This is erosion. These are the things that we have to deal with. At least talk to patients about it and give them an A plan, B plan, C plan, and a contingency plan in order for things not to get worse in their mouth. And as many times as you've gone over that with them, a lot of times, if they're not then taking the realm or the reins and then going with it and then helping you talk about it with patients, it's not sinking through. And a lot of times it doesn't sink through so well coming from the doctor who owns the practice. And the best way I can explain to that is my own hygienist. One of my hygienists, phenomenal, been with my practice the longest out of all the employees, been here longer than I've been here. She's been here 20 plus years. You know, I sat there, went over with her on lunch hours, after lunch hours, this and that. When did she feel confident enough in herself? And now going back and talking to the patient about it, when she took and came to my occlusion course. Again, she heard me, she heard Mike, but it was coming out of the office, sitting in a learning environment and actually being able to absorb the information where it's not you talking to them about that in between patients, where it's not you trying to teach them that, you know, after hours when everyone's trying to run home and get home to their family. When you're not sitting there doing it over your lunch hour where, you know, you're worried about is the food going to get here or where did we order it and who's my 2 o'clock patient? You know, it comes out of the office just like we learn in our best environment that way. And it helps your staff learn too. So I think that's really imperative. You hit the nail on the head. Docs definitely more successful in training their staff as well.
Everybody needs fueled up. Everybody needs a Vince Lombardi coach fueled up. I've had the same assistant Jan for 28 years, and I mean, she quotes you guys like some preacher quoting a Bible or something. You know, it's like John Nosti said this, and Samir Puri said that, and Gordon Christian said that. I set her down at David Hornberg's office 25 years ago. I want to ask you something about occlusion because I thought it was very obvious that in our lifetimes, one of the we just lost the man who invented implants, Dr. Brandmark, and in America, that Dr. Brandmark would have been Carl Misch. And Carl Misch started off with removable, and he mastered removable, and then he got into implants. And at the time, you were seeing all these people saying that implants would break and they weren't strong. I'm going back to 1987. I got to school when so many people said, well, until they can make a stronger titanium, and Carl Misch was saying, dude, the implants snap because you don't know anything about occlusion. And I thought it was very interesting how the people who mastered occlusion, they never had any problem with implant-supported dentures, and their implant-supported bridges were fine. And a lot of these people who keep saying, yeah, well, these crowns, you know, they're always coming off the implant, and it's always getting loose, and you got to screw them down better. And it's like, so I want to ask you two things. And when you talk about cosmetic dentistry, I think two big errors on cosmetic dentistry is if I go up to an American and say, describe a person worth $100 million. They always describe some man in a factory and all that kind of stuff, but it's not true. If you're worth $100 million in the United States, you're an older woman widow. And I have sold more cosmetic dentistry cases to older women in cash because when you're 70, you don't blink at trying to look 60. When you're 80, you'll pay 3 times the rate to try to look 70. And I think a lot of young dentists try to sell cosmetic dentistry to young, good-looking people when they don't have a dime. But man, every 7, and I'll never forget this, John. My great-grandmother died at 90, I think 99 and 7 months, or she missed 100 by like 4 months. And when you walked in her bathroom at 99, she still had the powder puff. She put on the lipstick. She spritzed the perfume. I mean, a 99-year-old lady wants to look good. And I want you to comment on that, you know, not diagnosing who needs cosmetic dentistry based on whether you date them or not. And then number two, a lot of the cosmetic dentists don't even realize they're cosmetic dentists because it's removable. And in the United States has 30 million people that are edentulous, and a lot of people, if I said to a dentist, describe a smile makeover, he'd say, oh, upper 10 veneers, and you should see Nosti or Hornbrooker, you know, blah, blah, blah. And I'm like, well, you didn't mention the lady who finally got sick of it all and pulled all of her teeth, and that denture is the cosmetic smile makeover. There's 30 million of them. Can you be a cosmetic dentist doing removable?
100%. I mean, you know, it's kind of funny. Uh, I fortunately I love doing dentures coming out of dental school, and I think that was part of. I think the people who loved teaching when I was in school were still the removable faculty. So I think I liked doing it. You know, unfortunately, when I first got out of school, I don't think there was a lot of people in my area didn't like seek me out for that. And then it started happening where, you know, our advertisements went on there, our website got published, and we were like one of the first guys in the area to really push out a website on cosmetics. And people started coming in and they started saying, hey, I want the smile that, you know, you gave for Jane or Julie, whoever it was. And then they'd pull out their teeth. And, you know, here it was, it says, well, wow, you know what? Now there really is the push to look for better materials, better labs to give these people the result that it can literally, compete with what I was doing with ceramics. You know, I think early on, it was porcelain teeth. I think that was the first thing was my go-to. Like, well, let's do porcelain teeth. I think nowadays with the nano hybrid resin composite teeth that are available, I mean, just look at manufacturers. There's maybe one manufacturer who is still fabricating porcelain denture teeth, and everyone else has gone away from it. Why? Because the nano resin hybrid teeth that are available, they literally can compete with what we're doing with all ceramic dentistry. Going back to, you know, guys like Carl.
What's the name brand that to? Is that Bluetooth or is that what is?
Well, there's, you know, Ivoclar has Phaneris, Candelor has PhysioSet. There's a couple different names that are out there. I mean, I have a tendency to favor Phaneris. I like the molds. I like
Who makes that? Ivoclar. Ivoclar. And spell that, Phaneris, spell that.
PHON. PHONARES.
Phoneris. PHONARES.
Yep.
Do you think Farran should be spelled with a PH?
No way.
When I get my denture, I'll do that.
Absolutely.
I'll say okay. So Phaneris, Ivoclar, what was the other one you said?
PhysioSet.
PhysioSet?
Physio. Like,
spell that.
Like PHYSIO set. SET.
What is the deal with pH and dentures?
I don't know, man.
Huh.
It might have been like fricative with a pH. Who knows?
So talk about that. So talk about these teeth. Is it kind of like what you're saying to me when I was a little kid? I never saw Starbucks coming because when I grew up in Kansas, every filling station had a free coffee pot with a little styrofoam cup. And then one man said, you know what? There's a market for a better cup of coffee. And when Starbucks started rolling out, I literally was thinking, John, I missed the whole Starbucks. I thought, you can get free coffee at every gas station in Kansas. Who would pay $5 for a Starbucks? And boom, everyone did. So you're saying that people will pay money for a better looking denture?
So, you know, I absolutely think you can be a cosmetic dentist and do dentures because I think more and more now with the baby boomer aging, increasing, and these people coming in, you know, they have dentures and they want to look the way that your cosmetic albums look like on your website and in your office. And I know nowadays with the materials that we have, we can give them an awesome looking denture that will rival what your all ceramics are looking like. And we have teeth like PhysioSet and Phaneris from Ivoclar, PhysioSet from Candelor. You know, these teeth look unbelievable. They're nano hybrid composite and they look great. You know, I think you have to get with a great lab technician who can custom characterize the denture base for you so it doesn't just look like a piece of plastic in someone's mouth. I think that too is imperative.
Name some names. Name a lab that can make a rockin' hot denture.
I mean, Brian Carson for Signature Smiles out of Fayetteville, North Carolina. I mean, that is my guy. That's my go-to guy. I mean, Brian just does an unbelievable job in dentures. I mean, he really is. This is what this guy does. And I know he's
what's his name? What's his www?
It's www, I think, signaturesmiles.com.
What's his name to Google?
Brian Carson.
Okay. Send that in your email notes. We'll put that in the transcript.
Absolutely will do. Brian's unbelievable. And, I think, a lot of people hate removable because, you do it the way you're taught in dental school. And then people come in and, you don't really know how to get the occlusion right. No one really uses Gothic arch tracers. And if you don't use a Gothic arch tracer, go back and look at one of my most recent articles in Dental Town on how to use one. Because really, when you're dealing with full dentures, occlusion is everything. If someone's coming in repetitively for adjustments and they continue, no matter what you do to the intaglio surface of the denture, and they're still having problems, I guarantee occlusion is the problem on that person. There's a reason why guys were successful in doing implants and why people are not successful in doing all ceramic dentistry or implants or even dentures. And I really think it boils down to occlusion. People want to have better looking smiles. I mean, you talked about it before, how many people in their 90s, they're still putting on makeup. They still want to look great. And, your patients are willing to pay for a top-notch cosmetic functional prosthesis. Ivoclar had someone run a survey for them. So an independent survey on people on the internet of denture wearers. And the numbers were staggering. 85% of people surveyed say their dentist never gave them a choice for a better looking or a better fitting prosthetic. And that alone, start talking to your patients about it. They're willing to pay a little bit more money for better teeth, for better processing like AvoCap or IvoBase, which hands down I think is better than traditional processing like Lucitone 199. The denture is going to fit better. It's not going to have issues where you take an impression, your impression rocks, and then you go to insert a denture and it falls out of the patient's mouth. That's a problem with processing. So I really think that guys and gals need to go back and revisit removable. I mean, because if you think you want to do full mouth reconstructions in your practice with all ceramics, I would challenge you. If you can't get it done in removable, I would reconsider your vision of wanting to try to get it done with all ceramics.
Well, this has been the fastest hour I've done on a podcast. I mean, this is just amazing. I've done two of your four guys. I've done you and Jason. Tell Leanne Brady and Mike Smith I'd like to follow up with them so that our viewers could get a full spectrum of your whole faculty with clinical mastery. Oh. And I want you to end this wrap up to the dentists out there. I want your close to be aimed at the dentists out there that are always telling me, times are tough, the economy's not good, blah blah blah. Yet, and I'm talking about the Civil War and World War I with the Spanish influenza and the Great Depression, World War II. Close with how there's this dentist out there that for probably 10 years his practice is the same. He's telling me, my town's going nowhere. It's been flat forever. No, I don't see anything great on the horizon. What do you say to that guy? Close talking to that guy who's been flat for a decade and thinks the sky is falling and America's glory days are behind us and nothing good to say.
Listen, I don't know an area hit harder from the economy than Atlantic County, New Jersey, where Atlantic City is closing casinos left and right. Tens of thousands of people have lost their job, and this is my backyard. This is where I practice, Mays Landing and Summers Point, New Jersey. And I can tell you that if you look at my numbers last year to this year, I was down a little bit, but if you look at my numbers from the year before, things go up and things go down, especially in a cosmetic and functional practice. The average income in my area is probably less than what it is in yours. Google Mays Landing and find that out. And I'm no different than you. Get on Dental Town, read what you can read for free. Look up everything you can about how to become a better dentist, how to do things a certain way. If you need areas and strengthen procedures, look it up, invest in the number one person, and that's yourself. And I can guarantee if you're listening to Howard, he gave me a lot of accolades, a lot that I don't deserve, but I'm very much appreciative. If you think that I'm something special and I've built something special, don't think that I'm anything different, because you can go and you can do it yourself.
And everyone wants to know, You're from New Jersey. Do you listen to Bon Jovi or Bruce Springsteen all day long? Which one of those two is the greatest?
You know what? My partners love Bruce, but I have to say I'm a product of the 80s and I love 80s metal, so I'm a Bon Jovi guy.
I love Bon Jovi. I love Bruce too. Hey,
Yeah.
John, thank you so much for your an hour of you. This has just been amazing. And go to Clinical Mastery, get fired up. And everybody I know that goes to a course with like you, they come back and they just start doing a whole bunch of bigger cases. They're more excited. They're more animated. They're all into it. And motivation is like deodorant. You need it every day. Go get some more skills in your toolbox. Go get a dose of John Nosti. Man, thank you so much for all that you've done for your patients. Thank you so much for what you've done for Dental Town. Thank you so much for your over-the-shoulder clinical mastery. John, you're I'm going to start calling you Dr. Bon Jovi Nosti the third.
Howard, thank you so much. I'm humbled and I'm honored to be here today. Thank you again. I greatly appreciate it.
All right, go Bon Jovi.
Take care.
Bye-bye.
Bye-bye.